All right, welcome back to week 3 of the worst month of your life here. Now this month of August is brutal for you guys, but it gets marginally better this week. One, because you guys are just better at dentistry now than you were a week ago. 2, we jump to the anterior teeth, okay? So things are just a little bit easier. Teeth are smaller. You can see a little bit more clearly because it's right in front of you, okay? So yeah, I'm hopeful for a pretty good week from you guys. And we have one less lecture. So here's our schedule for this week. You can sense the excitement. All right, so the stuff you guys really want to learn about. Anterior preparations, okay? Yeah, I mean, the principle's pretty similar, right? We talk about posterior teeth. You take a burr, you grind a little bit on top, grind a little bit circumferentially, slap a little temporary material, call it a day, right? So pretty similar. Let's just go through some of the parameters that we have for our PFM crowns. So instead of our occlusal reduction of 1.5 millimeters, we're going to do a 2 millimeter reduction at the incisal edge. So the way you'll do this is you'll take a burr. So our KR burr, how wide is that at the end of the shank? So at the tip it's 1.2, but how about the other end of it? About 1.8. Okay. So if you want to use that as a guideline, you can sink the burr at its thickest portion down its full length, and then maybe just a little bit more. Or you can just save that 0.2 millimeters when you end up finishing it. You can probably remove that 0.2. Okay? So the reason why we need a little bit more reduction there is because that anterior area is a little bit more demanding in terms of aesthetics. So as you look at the incisal edge of your teeth, you notice that it gets much more translucent than maybe a cuss tip, right? So again, we still got to make room for metal. This is, again, still a PFM crown. We still got to make room for opaque, but then now we also have our dent and enamel layer that we could use an extra 0.5 millimeters to get that aesthetic-looking porcelain, right? Our facial shoulder, still the same, 1.2 millimeters, and then our lingual chamfer is at 0.5 because we can do a metal color on that lingual surface because it's a non-aesthetic zone. So this wall here is going to be real tall. I want you to pay attention to this wall here. This is the challenge in the anterior region, is keeping the anatomy of the tooth. So remember, we want to try to get as even reduction as we can, but this lingual axial wall, we want to maintain some height here. All right. So remember, we talked about the total occlusal convergence of your two walls and your height to base ratio have an impact on your retention resistance form. So your resistance form, remember the difference between retention versus resistance? Somebody? Okay, who's whispering?
Retention is higher.
Right, so retention describes as you're pulling it away parallel to the path of withdrawal or the long axis of the tooth, and the resistance is any motion that's not parallel. So when you think about it, any tipping force, okay? So you can see here that this wall and the taper and the height is important to maintain so that we get a better resistance form. So see how that differs from our posterior preparation where both the buccal and lingual walls were of similar heights. In this situation, because it's an anterior tooth and the anatomy, this wall is obviously a little bit shorter. So we want to make sure that we got some parallelism or a good taper, a minimal taper between the two walls, and not to over taper it so it's just a blending of this whole surface. Okay? So pay attention to that. I'm sure we'll show a bunch of pictures. The idea of your second plane of reduction still applies, and this is probably even more important here in your anterior tooth. So you can see the color difference here. You got the blue towards the gingival half, and then the red is your second plane, and that's towards the middle to incisal half. So when you stick your burr in, so I'll show you from a different angle, it's probably a little better to see. So again, you're going to use your KR burr, that's 1.2 at the tip, to do this. So first plane, you see the angulation of the tooth, and then the second plane is a little bit more vertical, right? So definitely in this anterior tooth, don't skip your depth groove step here, okay? Because once you're going to lose orientation of where you are if you don't put in this second plane depth groove. You're not going to know how deep to put that. Because what's the disadvantage of under-reducing in the axial surface on the facial hair? Good. Everybody hear that? No? Okay. So I'll repeat that. Somebody said that it's going to, the opaque layer is going to show through a little bit more, right? So if you built that crown to the proper contour, there's not enough porcelain there to make it look nice. Or if you make it look nice, it's going to be over-contoured, meaning that, well, you had to bulk out the facial surface more than you wanted to, just so that you can make it look aesthetic with the porcelain, okay? So it's either going to be unaesthetic because the opaque layer, or two, it's going to be over-contoured and it's going to be more bulky than you wished, okay? So two-plane reduction on the facial, we're going to be looking out for that. And we're going to be repeating that, I'm sure, over and over again the first day. All right, so we talked about incisal edge reduction, 2 millimeters. This is the challenging part, I feel like. The lingual margin, maybe not so, but then getting your depth groove on your lingual surface, okay? That's a little bit hard to visualize. And it may be a little harder because you're using indirect vision too, because you got your mirror down there. But the suggestion is to use the coarse football diamond to reduce your lingual surface. Okay. So we can keep that lingual surface, remember, in a couple different materials. We can either do metal or porcelain. So in our case, we're doing a metal lingual surface, so your contact point where your incisal edge of your mandibular tooth is hitting the lingual surface is going to be in metal. Remember how far away from the metal ceramic junction do we want to keep that transition? 1.5. So you don't want them hitting close to where the metal transitions to the porcelain. Okay? If you're doing something porcelain back there with a PFM, obviously you're going to need a little bit more reduction. Okay, so, but in a non-aesthetic area, generally we like to keep things contacting metal if we can, because it's just more conservative with the preparation, as well as the less porcelain you have on these things, the less likely porcelain's going to chip. Okay, so that's sort of the anterior prep. And then similar things as you go interproximally. This is going to be easier to get through interproximally because you can see a wider embrasure space. And again, you want to keep, the hard part is keeping the gingival margin, or your margin, kind of in the same contour as your gingival margin with that shoulder burr. So it's harder to put curves in that compared to your chamfer burr. But as you get interproximally, one, you'll be able to see a little bit better, and it will be less chance of you over-tapering because you're looking straight down at number 8 when you start that. But you can still use that skinny chamfer burr to break the contact first and then carry a thicker burr through there once you've broken the contact. Okay? One of the things that you'll be doing as you get into the clinic too is this idea of a diagnostic wax up. So sometimes patients come in and then their teeth don't look like you would want them to. And you want to make them a provisional that obviously looks pretty nice because it's a preview of what the final is going to look like. Okay? So let's say a patient comes in, they had chipped like the incisal edge of number 8, right? So if we did our provisionals the same way that you guys have been doing on your posterior teeth, they're going to walk away with a tooth that's essentially looks exactly the same as they walked in, right? So in order to improve upon that aesthetics, what we can do is get basically a diagnostic cast or a diagnostic impression. So every time your patient first comes to our clinic, you're going to do a whole comprehensive exam. One of the things that you're going to be doing is making molds of their mouth so you can pour it up. And then on that stone cast, what you could do is add wax to it to make it look ideal, right? So the area that was chipped, well, you start waxing up your tooth, similar to what you guys did in your occlusion class with Dr. Okoria. So you guys remember that little exercise? You got a little bit of wax, okay? So once you got the tooth waxed up to the form that you like, then you can make a stent of it, and that can be done in many different ways. We've taught you how to do it with the PVS material. This is also a PVS material that you see here, this blue putty material, and this is stuff that we've played with in our dental materials class, right? Remember the guy that made the little skateboard with the little, who made that? Yeah, a little skateboard with a kid, right? Yeah. You guys remember that, where you mix the two, the blue and the white together, and you push it together, and it starts, yeah. So this is the stuff. And what category of material is this? It's a PVS, and there's two types of PVS materials, right? How do we categorize that? Addition and condensation. So the PVS that we had been using to make your final impressions, which one was that? Addition. And then we know that this is condensation by elimination, right? So what do we know about condensation PVS? Well, they have a byproduct. So this is why we don't use this material as a final impression, because since it has a byproduct, it's not going to be dimensionally stable. Turns out that this byproduct is ethyl alcohol. Okay? So you're going to have slight dimensional change in this material. So good for provisionals, right? It doesn't have to be so accurate that we're going to make a final off of it. But certainly not accurate enough to use as our definitive material to make a final impression for final crowns, right? So this material you'll have, Pedro will have this in the back. You're going to get a scoop of the blue, a scoop of the white. So one's a catalyst, one's a base. You're going to mash it together with your fingers, kind of like Play-Doh. And then you're going to essentially put it onto your tooth to make an index or a mold of that before you prep it. And that's what you're going to use to fabricate your provisional. All right? So I think that's chapter. Actually, somebody, let's take out your manuals here. All right, so here's pictures. Step 1, silicone mold fabrication. So knead the two parts together in equal volumes. Okay? And then you can see us putting it onto the tooth. So you're going to wrap it around and then push it into place. And again, same thing, you still want to use Vaseline to lubricate the tooth. Obviously, the Vaseline, again, is just for sim clinic purposes. You don't need to put Vaseline on the actual patient's tooth. And then you can clean up the interproximals a similar way if you need to with that DeMayo, or if you just pull it off and it comes off, then you're in good shape. But you'll trim it up, and hopefully pretty similar to what you've done in the past. Okay? All right, let's talk about biologic width. So this is a subject that we've touched upon before, right? And I think you guys have gotten some of it in your perio class. So the combined width of the connective tissue and junctional epithelium. So pretend you're the probe. And you guys have you guys started probing yet in your clinical orientation, right? So as you stick your probe in to the sulcus, that's the first thing that probe touches, right? So there's a little space or a pocket that we're trying to measure. So that's our gingival sulcus. If we were to carry that probe further, what are you going to hit? The junctional epithelium. And that's a hemidesmosomal attachment, right? So that could be severed if you probe too much, right? And then once you pass that junctional epithelium, what are you going to hit? Connective tissue, okay? So sulcus, junction epithelium, connective tissue. That's what you have to repeat to yourself over and over again until you memorize it, So once again, sulcus, junction epithelium, connective tissue. And that junction epithelium layer, that's held together by hemidesmosomal attachments. All right, so the idea is, how this relates to us is, where do we want to put our margin? So we know that there's 3 different layers, you can think of it, in our gingival complex. So again, sulcus, junction epithelium, connective tissue. Out of those 3 things, the connective tissue plus the junction of the epithelium, we're going to consider that, or call that, the biologic width of the tooth. So the average biologic width is 2 millimeters. So an anatomically average person, they're going to have about 1 millimeter per segment here. So your sulcus is about 1 millimeter, junction epithelium about 1 millimeter, connective tissue about 1 millimeter. All right? But this can vary, so this slide is just saying that sometimes your biologic width from patient to patient and tooth to tooth could be a little bit different. So in this situation, our connective tissue layer is 2 millimeters, thus making our biologic width 3. Right? But the total distance from the bone to the free gingival margin, that'd be 4. So it's just math. I know a lot of you guys got into dentistry because you guys hated math, but we got to do a little bit of adding and subtracting. I won't make you take the inverse tangent to find out the angle of a burr, but I'll ask you to do some arithmetic. Okay? Right. So how do we measure a patient's biologic width? Because we obviously can't take a cross-section of their tooth and then their bone and their gingiva like we were looking at before. So we got to find a way to measure that a different way. Well, the sulcus step you guys have done before. That's your periodontal probing. The question is, well, what other number can we get? Well, the other number that you can get is what we call sounding to bone. So you take a probe. Actually, before you do that, you want to numb the patient up in that area. So you anesthetize the soft tissue. Then you take the probe, and then you just jam it into the sulcus, and you stuff that down until you hit something hard. So the probe is going to sever through your junctional epithelium plus your connective tissue layer. Yeah, just jam it in there. Okay, and then when you hit bone, then you can measure the distance from the bone to your free gingival margin, right? So that's a measurement you get for sounding to bone. So that number minus the sulcus depth will give you your measurement for biologic width. So obviously you can't really tell how, so let's say your sounding to bone is 4 millimeters and your sulcus depth is 1. Well, how wide is your biologic width? 3. So out of those 3 millimeters, it's hard to tell how much of that is your junctional epithelium and connective tissue. But you know that combined, it's 3 millimeters. All right? So that's a number. The biologic width is something that, one, you'll want to know how to measure if you need to, because the thing that will happen is sometimes we violate this biologic width. And we're going to show an example of that coming up. All right? So here's an example of an anterior tooth with a crown that's prepped to the free gingival margin. So this is our equigingival scenario, which we like because it's easier to get an impression compared to a subgingival, and it's aesthetic because we're hiding the transition between the tooth and the crown. But there's times where we have to go a little bit deeper than we want, and we go subgingival. And we may go so subgingival or intraclavicular that we end up in the junctional epithelium. So what are a couple reasons why we may need to go deeper with our crown margin than we would want? Okay, so if we're chasing caries, right? At some point you got to remove all that unhealthy tooth structure. So you can imagine like let's say you have a class 5 restoration, right? Sometimes you got to go subgingival there because it's at the gum line and the tooth has demineralized below the gum line. So yeah, sometimes our caries goes beyond the sulcus and into this region. So you got to prep that way because obviously you want the crown to be sitting on sound tooth structure. Another scenario would be sometimes a tooth, let's say your cusp, like in a cusp tip in a posterior example, you have a big MOD and the facial cusp fractures off. Well, sometimes the fracture of that tooth, right, the part that it snaps off at is going to be below the gum line from time to time. Right? So in those cases, then you're sort of forced into having your margin meet the area where the break occurred. But most commonly, you're probably going to find some sort of caries is probably the number one reason. Or sometimes, just as the operator, you make a mistake and you go a little bit deeper than you want. So an iatrogenic issue, right? So you as a provider kind of elicited that violation of the biologic width. So in this case here, let's say this caries, we had to extend our margin deeper than we want. We would call this an invasion of biologic width, where the biologic width is violated. So when the margin is placed within the biologic width. So the question is, well, what happens when this biologic width is violated? And the answer is you get inflammation in that area, and then you have the potential for unpredictable bone loss. So let's read this real quick. One possibility is that bone loss of an unpredictable nature along with gingival tissue recession. So one of the principles you may want to know is that as the bone disappears, then the gum tissue will also follow where the bone is. So if you have some bone loss, a lot of times you're going to see the tissue also recede, because of course the bone supports the soft tissue. Okay, so that's why they say along with gingival tissue recession occurs as the body attempts to recreate room between the alveolar bone and the margin to allow space for tissue reattachment. So the body has this 2 millimeters of biologic width that it likes to have between any restorative material and the bone. And when you violate that, then it gets angry. And it shows you it's angry by turning the tissue red and then having the bone disappear. Okay? So also going to talk about, so let me finish reading this. This is more likely to occur in areas in which the alveolar bone surrounding the tooth is very thin in its width. So other factors that may impact the likelihood of a recession include whether the gingiva is thick and fibrotic, or if it's thin and fragile. So we'll talk about gingival biotype. There's differing biotypes. Have you guys heard that word from your perio? Okay. And then 2, you also have this idea of highly scalped and flat, or flat in its gingival form. Okay, so there's certain patients that are going to be more susceptible to having more bone loss just because of their genetics or their biotype. Okay, so inflammation and bone loss are the 2 things. And then with bone loss, that comes hand in hand with gingival recession. So it's similar things. All right, so clinical situations include removal of caries, iatrogenic crown preparation. So those are some of the reasons why. And you can probably add tooth fracture there too. It's something else you may see. So here is a clinical example. So you can see the gingival margin around tooth number 9. That looks more angry than the adjacent teeth. And why do you think that is? Because there's a violation of biologic width, right? Yeah, good. Okay, so let's see that in a radiograph. So you see the mesial margin of that crown. You see how close that is to the bone. The body likes to have a buffer, or likes to have a 2 millimeter biologic width in between, so that it remains happy. Okay. So here's another example. So the biologic width in this case is tooth number 9 that's been violated. And let's take a closer look at the crown prep. So we said here the crown preparation should follow the contours of the gingiva. So you'll notice with your anterior teeth, especially, and it happens in your posterior teeth too, that the shape of the interproximal gingiva isn't just flat, right? We have what we call this papilla, this interproximal papilla, that has some curvature to it. So let's take another view. So you see how there's a curvature where it kind of peaks up as you go interproximal. So you want to follow that same contour as you're prepping, and you don't want to go just straight through in a straight line connecting the lingual to the buccal. So you can see on the distal of tooth number 8 here, you see how the crown margin is way subgingival here, because if you took the level of the prep from here to the lingual, it's essentially just a straight line across. It didn't follow this curvature that you find in its natural tooth form. So if you were to reflect the tissue back and then measure or look at the bone, you would find that there's that same curvature in the bone that the soft tissue will follow. Okay, so you see, and then if you also notice how the cementum enamel junction, the CEJ, also follows that same contour in the interproximal region. All right, so when we look at your crown preps, as you go interproximally, follow the contour of the soft tissue. It's going to go up a bit and then go down. Don't go straight across, because you may violate that biologic width. All right? So that's the principle. All right, so now we're going to talk about 2 different ways to treat biologic width. The first one we're going to talk about is this principle called crown lengthening. So let's walk you through the steps here. So again, we said we don't want this margin so close to the bone. So how can we solve this problem? So one is crown lengthening, which is basically you reflect the flap, meaning you think of it as peeling away the gum tissue, and then you remove the bone so that you can reestablish your biologic width. So we'll jump back to this slide. But the original question, how do we retreat it? Well, we're saying the margin's too close to the bone, so let's just get rid of the bone so it's not so close anymore. Okay? So reflect the flap. You'll pull back the soft tissue. You can take a little burr here and just start hacking away at the bone. Okay? And then you can take some hand instruments and kind of refine it. But the principle here is you remove bone away. And they have special burrs so that you can stay away from the tooth and won't damage the tooth. And then you suture that back up, and then you let that heal. So as that heals, guess how far away your margin is from your bone now? Wow, it's a lot further away than it started, right? So now we're not in violation of biologic width. So after healing, this whole complex between your sulcus, junction epithelium, and connective tissue gets reestablished as it heals. Okay? So now the tooth is happy. The body's happy. It's got its biologic width reestablished. Okay? Pretty straightforward. Crown lengthening, right? Okay, so if we were to compare the pre versus the post crown lengthening, let's take a look at what happens. So this is how we started off the No, this is where we ended, right? Let's go back, yeah. Yeah, so this is after crown lengthening, right? So let's look at the length of the tooth that's exposed. Let's compare that to where we started from. So we're looking at free gingival margin to the incisal edge. Well, after crown lengthening, which got taller? Or the tooth looks longer now, right? Because you remove bone, which then means you've removed the, which means that the gingival margin has migrated apically as well. So you're going to have a difference in the crown height here. So after crown lengthening surgery, the crown of the tooth looks longer. That's why it's called crown lengthening. Right? Things starting to make sense. We try to make it easy for you guys. The gingival margin is moved, not as moved. The gingival margin as moved is moved apically, while the incisal edge of the tooth, we maintain it at the same length, right? We haven't really altered the incisal edge. So if you're doing, let's say, an anterior tooth, you got to be cognizant of this, because sometimes what you'll find is our gingival margins will be at differing levels because we've had to move the bone away or remove some of the bone. Okay? So as you're treatment planning and thinking about these cases, one of the things you want to talk about or think about is where the smile line is, and we'll get to that in a subsequent slide, right? So when the patient smiles, you'll ask them, give me your most exaggerated smile. Or sometimes I'll tell them to grimace because their smiles look so funny. Grimace, they kind of like, ugh. So how high can they get their lip to come up, right? Because if their lip never goes above that free gingival margin, then who cares what this looks like? Because the only time somebody sees that is us when we take some retractors and pull that away, right? Okay. But let's say they have a high smile line. You know, some people when they smile, they show all their gums and then some, right? Well, in those situations, for a more aesthetic result, you're going to want to consider the gingival contour of your anterior teeth, okay? So maybe you end up doing crown lengthening on the anterior 6 just to make them even, right? So anyways, the principle is you remove bone, the crown of the tooth is going to look longer in crown lengthening, assuming that you keep the incisal edge at the same position, that you haven't altered that. All right, so that's the first way to to resolve this issue of biologic width. Option number 2 is orthodontic extrusion. Okay, so another method of treating the violation by biologic width is a rapid orthodontic extrusion. So for those of you who have, you guys all know what braces are, right? You put some brackets on and then you can move the teeth around. Okay, so one way is let's just take the tooth and just pull it down. Because what happens as you pull the tooth down? Well, the margin moves away from the bone, which is good, right? We want a safe distance from the bone to the tooth. So we're going to erupt that with braces, essentially, and pull that tooth down. And then, obviously, that as you pull the tooth, there's bone kind of filling in that socket. But now you can reestablish your biologic width. So in this scenario, let's take a look at the difference here. So in our situation, if you do rapid extrusion, the tooth just comes a little bit longer, right? So our gingival margin looks the same. But what happens to our incisal edge as we extrude the tooth? It's going to be longer. So obviously, let's say you're doing, there's tooth number 8 that's an issue. Well, you don't want 8 to look longer than 9. So the solution to that is, well, you just reprep. So the incisal edge of the extruded tooth is more apical than where it started. However, the gingival margin is at the same height. So to make it to the same incisal edge as where it started from, you would just simply prep the crown down more so that you get it to the same height, right? So the only thing you got to watch out for there is where your pulp is. Because, of course, we're doing more incisal reduction than maybe normal, so you may end up encroaching upon the pulp. Okay? So that's one consideration for orthodontic extrusion. So, where am I going with this? Oh, okay. So let's do this. How about in your groups? So there's this idea of crown to root ratio, right? So how tall your crown is, how tall your root is. So for a favorable crown to root ratio, you want your length of the root to be as long as you can, right? So if you were to take a look at these two scenarios in terms of orthodontic extrusion versus crown lengthening, why don't you guys talk in your groups, which is going to give you the more favorable crown to root ratio? All right, who's a volunteer there? Somebody? Okay, all right. So let's do this, all right? We have two options. You got 50% chance, either orthodontic extrusion or crown lengthening, right? So hopefully your table came to some consensus. So on the count of 3, if your table chose crown lengthening, I want you guys to raise your hand. Okay, 1, 2, 3. Being a more favorable crown to root ratio. Okay, so everybody else, there's some confusion. Okay, and then everybody else said orthodontic extrusion, right? Okay, thank you guys. Just want to get a poll. So let's do this. Some group that said crown lengthening. Let's give your rationale as to why you chose that procedure as having the more favorable crown to root ratio.
Well, we took it as we're students doing it, and we're going to go deeper than we need to. That's what we thought.
So what do you mean by deeper? So crown lengthening.
We'll take off more bone than we should.
So if you take off more bone, does that lead to more favorable outcome in terms of crown? No.
It would be a less favorable.
Right. So therefore, orthodontic extrusion is going to give you the better, according to your rationale. Confused as hell right now. Okay. That's fine. Okay, crown lengthening. Somebody else on the crown lengthening team.
We said crown lengthening because it's faster, and if you do the ortho one, you risk potentially hitting the pulp, especially if it's a younger patient.
Right. So those things are true, but the question was just in terms of crown to root ratio, which is going to be better, right? So in terms of, okay, right, if you have something that is very little tooth embedded in the bone and a very tall crown, that's not very good. You want to maximize the amount of tooth in the bone and then, in a sense, limit how tall your crown is. So yes, true. It is faster for certain situations. What the slide, if we go back to the slide, and we haven't talked about it yet, but your anterior crown lengthening, we actually would want that to heal for an even longer time, sometimes as much as 6 months for that tissue to stabilize. Because the last thing you want is for you to prep, right, crown lengthen, the healing starts, and then you make your, let's say you cement your final crown, and then month 4 into this whole process, the tissue creeps just a little bit more apical, and then now you can see your junction of your crown to your tooth. So it's true in the sense the surgical procedure will get you done quickly, but in the anterior region, we tend to wait a little bit longer for the healing so we know that tissue is stable. Okay. Okay, question? Oh, you have an answer. Okay, go ahead.
So we went with crown lengthening to be the more beneficial one, because with crown lengthening, you're reducing your facial part of your bone, whereas with ortho, you're actually pulling the whole tooth out, so you're losing from both facial and lingual.
Okay, so yeah, there's a couple things. That's a good point. So let me clarify this point. Your crown lengthening, you can do that on any surface of the bone that you want, right? So you can do it on the facial, the lingual, interproximal. Most of the time, though, when you crown lengthen, you're going to bring the whole complex fairly evenly down because you don't want the bone to be, you know, have a Jurassic dip in it. Okay. So the example we showed here with crown lengthening just shows the facial, but most of the time you're going to do crown lengthening in multiple parts of the tooth. Okay, so that's a good point. All right, anybody else with crown lengthening? Did anybody do any math? How about, yeah, go ahead.
A longer incisal edge, so then we're thinking the reduction would be more in terms of because you've extruded too far, so you need to compensate for that. Mm-hmm. So that's why you'd have less root to crown ratio, because you have more of a crown ratio now to the root, where you want more root. So.
Right. Okay. So let's go back and let's put some numbers to these examples then, right? Right. So let's start with our crown lengthening example here. So if we go back and we started, let's say our crown height here that's exposed from here to here, we'll say that's what? 8 millimeters, let's say. Okay, so that's how much of the tooth is showing. And then from that point here, the distance from here to this apex, okay, we'll call that what? 16. Okay, we got 16, and then we have 8 for a total of what, Kimball? 24. Very good. All right, so these are just random numbers that we put in, okay? So let's say we crown lengthened. We needed to remove 2 millimeters, let's say, okay? So everything gets moved this way 2 millimeters. So now what is the length of the tooth now that we see? 10, and then the length of the root is 14, right? 16 minus 2, okay? So our crown to root ratio would be 10 divided by 14, right? So what number is that? Somebody can put in a calculator later, but 10 over 14, okay? So let's go over the same scenario except with orthodontic extrusion. So we start off with the same scenario, 8 and 16. This time we're going to extrude the tooth 2 millimeters. Okay? So the amount of the tooth that's embedded in the bone is going to be what? 16 minus 2. We still have 14 millimeters, right? So the amount of tooth that's in the bone in both, or if you think of it that way, it's not all 14 millimeters in the bone, but 14 millimeters, let's say, from this free gingival margin to the apex, and then we've extruded this tooth 2 millimeters, right? But then remember, we prepared it down or prepped it so that we get back to the original incisal edge length, because we said that we didn't want that tooth to be longer than the neighboring teeth. Okay, so the 2 millimeters that we extruded, we end up chopping off when we reduce that. So the distance from your free gingival margin to your incisal edge is still maintained at 8 millimeters, right? So 8 millimeter long incisal edge, 14 millimeter long root, okay? So now if you did the math, which is going to be a more favorable crown to root ratio? Well, we know the root lengths are the same, but in the orthodontic extrusion example, that crown height is shorter than when you crown lengthened. Therefore, when you extrude it, it's going to be more favorable. Okay? So essentially just kind of put in numbers and then do a little bit of math. You know, it's not the favorite subject for most of you, but kind of be able to visualize that, because these turn out to be very good test questions. Okay? Question? Yeah. I mean, it's all relative. However you want to draw the line and do your numbers, it's going to be the same principle. Your root length is going to be, or the part that's in the root is going to be the same, but your crown is going to be shorter when you do orthodontic extrusion.
Taking the clinical crown length,
Right.
it's going to be the same, I think, ortho and extrusion, or ortho and.
So clinical crown meaning the part that sticks out above the gums versus the anatomic crown. Yeah. So I guess for the sake of simplicity, it almost doesn't matter what your anatomic crown is, right? Because that's what CEJ, that's how they measure the length of the, because you're going to be crowning a tooth, putting like a crown on the tooth. So it doesn't matter what the crown or the CEJ is. What really matters is what it looks like when somebody smiles, right? So we'll consider the clinical crown length is sort of the most practical, or the one that you want to consider, because that's what we deal with in real life, right? So no patients in there going, oh, but my anatomical crown is blah, blah, blah. You know, they don't really care what the CEJ is, okay? All right, any questions about that principle? So crown lengthening versus orthodontic extrusion, biologic width. Remember that's sulcus, junction epithelium, connective tissue. The average is 2 millimeters, but it can vary patient to patient. If you violate biologic width, there's a couple things we can do. Orthodontic extrusion, crown lengthening. Violation occurs for several reasons. Caries, iatrogenic, root fracture. Okay? So that's that lecture summarized in about 3 sentences. All right, so let's talk about so this is stuff, this is no longer concepts, this is just stuff you have to know. So just spend the time to, I guess, memorize these things. Yeah, so let's go through it quickly. So thick, normal versus thin biotype. So we talk about this when we said people with thinner biotypes are going to be more prone to gingival recession. So that's true when it comes to biologic width invasion as well as just any type of recession that you see. Okay, so with the thinner biotype, you generally see a thinner alveolar housing. So look at the bone surrounding the teeth as well. Right? You see how the thin biotype also has thinner amount of bone. Okay, so there's a correlation between gingival biotype and the thickness of the alveolar bone. So that's that slide. And one easy way to determine if somebody has a thin biotype is, well, you put a metal probe in there, in the sulcus, and if the metal of the probe can be seen through the soft tissue, then we would consider that a thin biotype. Okay? So, of course, if it's a thicker biotype, normal or thick, that's going to mask the color of the probe underneath. So we have thin and scalloped, so that's the picture on the right, versus thick and flat. So that's also correlated with the amount. So somebody that has thinner and scalloped tissue, you're going to see that resorb a little bit more, or it's going to be more likely, or you'll have a higher chance that you're going to have some recession if you violate that biologic width there. Okay, and you get those black triangles. So let's look at the papilla height. One thing that, one principle that we would need to understand is if you look at our facial gingiva, right? So if you were to measure the distance from the free gingival margin to the bone, what's the distance that we typically see? We would say that's 3 millimeters, right? One for the sulcus, one for the junctional epithelium, one for the connective tissue. So that's what that bone scallop 3 millimeter average designates on that left side. But when we go to your interproximal region, we notice that we have a longer distance from the tissue to the bone. So when you guys have probed your classmates' teeth, what's sort of a typical sequence that you get in a healthy tissue? You get some like 3, 2, 3, 3, 2, 3, right? Or 1, 2, 1. Or no, sorry, 2, 1, 2. Right? So why is it that your interproximal tissue is deeper than your tissue on your straight facial? So this is a principle that we want you to know, is that your interproximal tissue is deeper, or your sulcus depth, you can think of it that way, is deeper because you have 2 teeth there pushing that tissue so it forms this papilla. Or in this textbook, they call it a soft tissue scallop. So there's this beanbag example, right? Let's say you had a beanbag sitting on the floor here, and you had one person sitting on the beanbag, and then another person sitting on the beanbag, and they're back to back to each other. What are you gonna find as they both sit on that beanbag in between their butts? Right? The beanbag is going to come to sort of a point or an apex. You're going to have this material that kind of squishes and it gets elevated, okay? Because 2 people are supporting that beanbag from different sides, okay? It's going to kind of pump it up just in that area. What happens when one person gets off the beanbag? Well, that area is probably going to collapse, and it's going. So the principle is, interproximally, you get a deeper sulcus depth because the 2 teeth kind of push the tissue up a bit. But the minute you remove that tooth, so in this situation, we have multiple teeth missing here. What do you think the measurement of this sulcus is? 1. It's going to behave like your facial tissue or gingiva because there's no tooth here supporting it. Okay? But when you have 2 teeth, interproximally, you're going to have a little deeper sulcus. Okay? So that's why when we ask you to pack cord around a tooth for your final impressions, it's easiest to start in the interproximal region. because you got a little bit more depth there that you can stuff that cord in to get it started. Okay? So when adjacent teeth are removed, the interproximal gingiva will behave like the facial and lingual gingiva. The teeth no longer support the soft tissue, thus the papilla will collapse. What do you think happens when you restore the space? So in this case, we did it with implants. Well, you would think that the papilla would be, you'll get back to where you started from when the teeth were there. Okay? So the presence of teeth will help push that soft tissue and papilla back to its form. Okay? So here's one of the principles that you'll have to know is when, so they did a study and they measured on different people the distance between the crest of bone to where your contact point of your anterior teeth touch, right? Apical portion of the interproximal contact point. So they wanted to find out what distance can you have and still maintain that papilla completely filled with the soft tissue. Okay? So the question is, from the contact point, and let me come here with my mouse. So there's bone underneath here, right, to this contact point. So what distance can you have to maintain the papilla fill in this interproximal region? Because we would say that this scenario is less aesthetic than this scenario, right? We would say that these black triangles don't look as nice because it shows that you've aged and your gum tissue has receded, whereas this looks better. Okay? So that's the basis of the study. So what they did is, this is the number or the distance from the bone to the contact point. So 3, 4, 5, and then so they took all these patients and then they measured that distance and then they took a photograph and they just said, or they asked the question, is this papilla filled? Meaning, is the triangle present or not? Right? So let's jump back to the little chart and the little study. And then, so this is the percentage of the papilla present or not. So we find that if the distance from your bone to your contact point is 5 millimeters or less, you're pretty much going to have that papilla filled in 100% of the time. As you lose bone for whatever reason, or if the contact point is for some reason altered so that you have 6 millimeters from here to here, only 56% of the papilla, 56% of the people that have this 6 millimeter distance will have their papilla space filled. Okay? And obviously, as that distance gets larger, you're going to have a decreasing percentage of people that have that papilla filled. Okay? So that's that principle. The distance from your bone to the apical portion of your interproximal contact, if you got 5 millimeters or less there, you're going to have your papilla filled. Papilla filled is good because in our society, we would say that this looks not aesthetically pleasing, and this looks very aesthetically pleasing. Cool? Papilla height. Okay, we also talked about gingival display, right? High smile line versus low smile line. In this situation, we probably don't have to pay as much attention if we're going to crown lengthen, let's say, to where the gingival margins are and evening those out. Because whatever we do here, we get saved by the fact that their lip doesn't show it. Okay? And again, capture a picture at their exaggerated smile, not their normal, because sometimes they'll kind of smile real big and you don't want that to show. And here's an example of one that's a high smile line. In this situation, we have to be very careful about either crown lengthening or aesthetic parameters because, man, they can see any errors that we make here. Okay? So they'll be able to see, like, for example, the junction of the tooth and the crown if we didn't prep the margin close enough to the sulcus. Or if we crown lengthen, we end up with uneven gingival margins. Okay? right? So average smile. So we had high, low, average. Okay, so on average, females have a higher smile line compared to males. So just know that. Incisal edge display. So we talk about where should your incisal edge be, or how much does it show at this rest position. So we have two positions, or the rest position is key for us in terms of that's a, I guess just sort of a standard in which we can measure. It's fairly repeatable, right? You get them to relax. You say relax, and how much of your incisal edge shows. Okay, so that can be a little bit more consistent than smiling, because every time they smile, maybe they'll smile at differing amounts. So it's harder to consistently measure the amount of display, right? So they took a bunch of patients and they split up by age group, and then they measured the amount of incisor display in this repose position. So if you're 29 and younger, you're going to show a lot, right? About 3.3 of your maxillary central, and you hardly show any of your mandibular central. What happens as you age? Right? Everything starts to sag. So all your collagen and all that, it all breaks down, right? So your lip position is going to droop a little bit lower. That's why as people move on in age, they're going to show less and less of their central or their incisors in this repose position, and then they're going to see more and more of their mandibular teeth. Things just kind of droop as we get older. Okay? So that's that principle you need to understand, incisal edge display. So when you rehabilitate somebody and you want to design crowns for them, you kind of want to consider their age, because that may have an effect on their incisal edge position. Okay, sometimes it looks funny to give a 7-year-old 4 millimeters of incisal edge display at this rest position. It just doesn't look natural. Okay? Or if you're designing some crowns for a young person, you don't want to hide all the tooth in that rest position. You want them to show a little bit, because it makes them look more youthful. All right? Simple? Okay, males versus females. On average, females have greater incisal edge display. Of course, we want our females to look more youthful, so we want to make sure that they have sufficient display. Okay, so midline. This is an interesting study that they did. So what they did is they showed a bunch of pictures of people with differing dental midlines. Okay, so they took a picture and they've essentially cropped it and started moving it to the patient's left side a millimeter at a time. And they showed a bunch of people, lay people, dentists, orthodontists, I think, and they said, at what point does this start to look funny, right? So, and they did the same thing with the angulation of the tooth, right? So they said, okay, move the incisal edge of the contact millimeter to one side, then 2 millimeters, 3 millimeters, 4 millimeters. So comparing the perception of dentists and lay people to altered dental aesthetics. So what do you think they found? It was actually pretty interesting. A maxillary midline deviation of 4 millimeters was necessary before orthodontists rated it as significantly less aesthetic than others. However, general dentists and lay people were unable to detect even a 4 millimeter midline deviation. Right? So if we go back here, the bottom right picture, that's a 4 millimeter deviation from the midline. But the principle is, when you're looking at somebody, we don't really notice that even at 4 millimeters. Pretty interesting, right? However, when it comes to the cant, or the angle of the midlines, what do they find there? All three groups were able to distinguish a 2 millimeter discrepancy in incisor crown angulation. So the principle there is, as you do these anterior aesthetic cases, you gotta nail that cant of 8 and 9. Because if you deviate from that just a little bit, the patient is going to be able to pick up on it. Your dental midline, if you're off by 4 millimeters, man, most people can't even see that, right? And even if you look at our dental midlines as they correspond to our lower So upper to lower. Yeah, everybody take out your mirror. See if. Yeah, everybody get out your camera phone. Take a picture of your teeth. All right, come on, everybody. Let's just humor me just for a second here. Take out your phone. Take a picture of your teeth closed. How many of us have our upper and lower dental midlines off? Okay. So how many people notice that about your classmates? Probably not very many, okay? So as you go along in your dental career, you guys are probably starting to do it a little bit already, but when you meet somebody for the first time, what do you notice about them? It's usually their teeth now, right? Just a habit you can't break, and it's terrible because you judge people by it. So you can pick up like little things like, I'll see, it's a PFM, or it's, you'll pick out those things. But it's hard to tell when their dental midlines, maxillomandibular, are off. We generally don't notice that, okay? So studies are interesting because it places the emphasis on what we should be kind of honing in on, right? What are the important factors for us to create an aesthetic restoration? Right. So incisal edge position, that's key. The cant of the crowns is key. Some of the things that aren't as significant that maybe we don't have to worry about as much is dental midline or even gingival margins when the patient has a low smile line. Okay, so we got to start putting these principles together. Okay. All right. So that kind of summarizes our anterior considerations for crown preps.